You have the floor, sir.
Yeah, good morning, everybody. My name is Oladapo Adewuya. I'm a cardiologist working for R-Jolad multi-specialist hospital in Lagos here. And I'll be taking us through causes of sudden death. And this is the beginning, so everybody should pay attention. Okay. So here we go. And just a second. Just a second. Okay, here we go. Can you hear me, please? Hello?
Yes, Dr. Adewuya, we can hear you.
Okay. Good morning, everybody. So we'll talk about the causes of sudden death. You can see in this photo about somebody who is being resuscitated. I mean, probably they're trying to prevent sudden death from happening in this patient. So briefly, R-Jolad Hospital we here are very scientific, we're practical, protective, and futuristic. And we're also involved in medical training. We use the latest techniques to treat our patients. And honestly, we're sort of experiencing wide patronage from people who have traveled out of the country and who are also trying to continue their treatment here because of the outcomes, the positive outcomes we had. We've had almost like 99.8% success rate of care of high impact cardiovascular diseases because we're a consultant here. So you have a high chance of surviving in R-Jolad more than anywhere else in the world. So what is sudden death? It's we can define it as an unexpected demise within 1 hour of onset of symptoms, or when death occurs unnoticed within 24 Okay, so I guess we adjusted that. Okay, so sudden death itself has been reported to occur in an increasing fashion in Nigeria, and it stems from various diseases. We should try not to kind of ascribe sudden death to mystical forces or witches or religious things. I mean, the causes of sudden death, as we go along, we will see that it cuts across every gender, every race, and every nation. I mean, that's geographical medicine. It cuts across certain kind of tribes and certain kind of existence in life. So when it occurs, when it's about to occur, when there is a medical condition, you have to seek the best medical care. And awareness is critical in any disease prevention, treatment, and control. So we have to go a little bit back to the history of what it means to die suddenly. And it goes back to almost the 16th century, almost 4,000 years ago, when somebody is called a Gaston de Foix. He had a contact with icy water and died suddenly because he felt tightness in his chest. And he said, I'm a dead man. Oh, God, have mercy on me. Well, medicine was at his almost non-existent then. Scientific approach to medicine was non-existent there, but Hippocrates had described something related to it. So then in Rome, you had people like Herbert, who first described angina pectoris, and von Bezold, who also talked about cardiac arrest when it comes to occlusion of vessels. So we can appreciate how the Western world has been documenting their findings over something they could not really understand. but they felt it was claiming lives, and they just could not. They just described what they saw and wrote it down. So you talk about now we're in the 20th century or 21st century, and history has progressed. I mean, medicine has progressed to now that people have an organized way of looking at things. And you talk about research, which is organized curiosity. So you talk about a group of inherited diseases called channelopathies. I know my audience is really wide and cuts across all ages and stratas of society and things like that. So I'll try to make things really simple and also give in the content that would really benefit the people who are highly up there. So you talk about channelopathies, that is things that affects the cells, that conditions that affect the cells without any organic cause that can lead to people dying suddenly. So, but try not to ascribe it to mystical forces or somebody doesn't like you and kills you mysteriously. No, it's usually something that is there that you cannot see in the person. And you can see this slide is telling us about, it's showing us about a physical activity taking place and this young man collapsing and cardiopulmonary resuscitation and probably advanced cardiac life support taking place. This patient is likely going to survive because it's in an advanced setting. And many people can think about or remember the Danish footballer Eriksson that fell down during the World Cup and his heart stopped and they had to restart it. Right now, he's still playing competitive football, though he had to move on. For those who like football, he had to move on from Inter Milan to Europe, to UK, and he's still playing top flight soccer. So sudden death will always want to occur, but we can prevent it. But at the same time, let's go to some epidemiology. Let's see how, because you ask yourself, how common is it that people just die suddenly? It's only happening in my hometown. And in the US, we found out that the incidence of sudden cardiac death is almost like the size of a whole town. People just die like that. And even with the advanced treatment and management and everything there, people still go down. In Europe, it's even worse. 50 to 200 per 100,000 people. In Africa here, if you try to look for causes of sudden death, what comes up is sudden cardiac death. But at the same time, it's also rising. The prevalence, the incidence of sudden death is rising, but it's mainly sudden cardiac death because 90% or the greater percentage of causes of sudden death is usually through the heart. And you can see this pie chart here. You could talk about, it's talking about causes of sudden cardiac death in athletes less than 40 years old. And it's saying that in less than 40 years old, you have a large proportion of people who have hypertrophic cardiomyopathy at 36% and other likely causes of sudden death that are spread over the assessment. You can see congenital anomalies, then mildly increased cardiac mass, you talk about ruptured aorta, talk about tunneled LED, that's the left anterior descending artery in 5% of people, and others, dilated cardiomyopathy, arrhythmogenic ventricular contraction, right ventricular contraction, all kinds of anomalies that we don't see with our eyes. And all this can lead to sudden death in people less than 40. So in sub-Saharan Africa, sudden death has been increasing, and it comes with chest pain. That chest pain you have that you ignore, that you apply a rub or a boniki, or you just say, I'm trying to grow older, I'm stronger, or I went to the gym. That's sudden death. That chest pain that you experience, don't ignore it. Come to the hospital, come to R-Jolad. Let us evaluate you, and you'll be out of it. You'll be able to prevent anything catastrophic happening to one. So now, we want to bring this sudden cardiac death, we want to bring it to our our living rooms, and in our population. We want to show you people who have really gone from sudden death. All this information is on the internet, and so copyright is not really an issue. It's everywhere. So, but you need to see that it cuts across all strata of society, and one has got to have a scientific approach to it. People can die anytime, but you have to find out what is going on. So you see now the deputy governor of Borno State then, long time ago, died in his sleep of cardiac arrest. Then one of the commissioners in Ondo State died in his sleep at 54. 54 is still young, you know. Then one of our presidential candidates also died in prison when he was about to be released. And everybody knows him, the uncrowned president of Nigeria. And one of our renowned people said, oh, he was surprised over the sudden death that happened in him. People have all kinds of explanations for his death. But we in the scientific and orthodox medicine think about the information that science gives us about the condition of the person. And when you look at the autopsy results of President MKO Abiola, his heart was so diseased, and his autopsy was done by renowned people who apparently you can trust them. And though there's a margin of error, but they found that there was a pinpoint narrowing of the arteries of the heart and marked thickening and enlargement of the heart. And that leads us to think of vulnerable myocardium. Vulnerable means something that is likely to go through some kind of event, vulnerable, being at risk for something. So his heart was already at risk. The myocardium is the heart muscle itself. That is, his heart muscle was already diseased, and anything will happen anytime. So you see, another person also died of sudden cardiac death. This was during the Governor Amboli's regime in Lagos. Was playing soccer, and he just died suddenly like that. He was certified fit, not playing soccer. Then another person came from Dubai, and that was it. He died suddenly too. And so in these situations, we have to make sure, sorry about that. So in this situation, we have to make sure that we try to find out what is really causing people to die young. So we know about a lot of young people may not know him, but he was a very patriotic man. He was actually my star in football. That he was playing in Europe and he was called home to play football, and he suddenly collapsed in a game. And you can see all the people around him. We're not sure whether all these people around him trying to save him was Sam Okparaji. He collapsed on the field while playing for his country. A very strong midfielder, talented, and all those around him, we are not sure whether they have the basic life support or advanced cardiac life support training. But you see, if you superimpose this in what happened in Europe, I mean, the player that went through this kind of experience is alive today, and that's Ericsson, still playing soccer. So this topic is so important that it was brought by popular demand, and R-Jolad Hospital is the place where most of the specialists here have this basic life support and advanced cardiac life support training, and we can make a difference in somebody dying or not. So another case that happened in Nigeria is a case of some referees who went for their testing program. They were removed from the list, probably because they failed the test, or somehow the Nigerian factor. They found their names back on the list again as the referees who could qualify, but they passed away due to sudden cardiac death. So one of our renowned professors in Nigeria, she's also a cardiologist professor, Mrs. Akim Hussein, also documented that the most common cause of sudden death in Nigeria was hypertensive heart disease, accounted for 86.7% of cardiovascular diseases. And he said, he also mentioned left ventricular hypertrophy occurring in most of the patients. So most people will have left ventricular hypertrophy and they won't know. That paper was published, she published that paper in 2013. Thank you very much. So we now look at it. We now focus critically on sudden death. This slide shows us about advanced cardiac life support. We're teaching these young people how to really apply the advanced cardiac life support in hospital, in young babies or babies who were going through, who could die anytime. We're trying to resuscitate them, which is part of the training of advanced cardiac life support to prevent sudden death. So in the first decade of life, sudden death is rare because of increased vagal tone and other kind of qualities that a baby has. They have a kind of stable autonomic nervous system. But as we grow older, though at that time, sudden cardiac death can still occur in babies. You have sudden infant death syndrome, but that may not be the topic, the main focus of this presentation. But in young people, when they are playing sports, you find out that they can have, like I mentioned, hypertrophic cardiomyopathy and all of that kind of causes that I mentioned before. Channelopathies, these are conditions you don't see with your eyes. So it's very easy to ascribe sudden cardiac death to your neighbor killing you or somebody you owe money, doing something to you, or that kind of thing. But it's things that causes you don't see. They're right there inside the person. So we'll tell you where R-Jolad comes in because we have specialists who can recognize the likelihood of somebody going into sudden cardiac death and reverse it before happening. So this graph is very important because It shows us the association of increased risk with age, increased risk of sudden cardiac death with age. You can see that right here, when you are young, 20, 30 years of age in adolescents and young adults, it's mainly the likely causes of sudden cardiac death are things that you still don't see. Once you hit the age of 40 and above, you see the graph goes off, a sharp increase in the risk of people dying suddenly. So over the hill, the Americans will say, you're over the hill. And once the general population, once they're above 35, you find out that you have advanced heart disease as high risk, ischemic heart disease, conditions that you really don't know about. But when you come to the hospital, you can be able to identify those risk factors. And R-Jolad being a hospital where we try to look at these cardiac risk factors, we can do a lot in reversing this possibility of you being high risk. We can reduce your risk level from being high risk to low risk. So you see, the 5 common causes of sudden death are mainly cardiac. And if you look at this table also, or look at this graph also, oh, something has disappeared. You see that when people are playing sports, the kind of sports that you can play that likely leads to sudden death is the first one is usually basketball here. Somehow the editors have chopped off the top of this graph. But I, being the originator of the slides, can tell you that the highest one, the sudden cardiac death, the atraumatic, that is the number that is highest here, the sport that predisposes to sudden cardiac death is basketball. So we are a soccer nation, so we can say we can avoid a large number of people dying from basketball. But overseas, as well in America, you have a lot of people playing basketball, and they're more predisposed to sudden cardiac death through basketball. So the sudden death goes through fatal arrhythmias. The heart will just beat irregularly, and you find that the patient will just be breathless, and you find that they just go down. Acute myocardial infarction, and then the intracranial hemorrhage. Acute myocardial infarction means heart attack. Intracranial hemorrhage, bleeding in the brain, then or a clot may occur. Sometimes the vessels in the body, the big vessels, the aorta, will just rupture, tear like that, and you will not know, and the person will just bleed to death. This information was got from very reliable sources, the Bible of Cardiology, Brownwald, and the book mentioned 128 causes and contributing factors to sudden cardiac death. 128 likely causes. So I'm sure there'll be more now because a lot of studies are still going on. So I'm not saying everybody will have one, but I mean 128 likely causes of sudden cardiac death. All right, so what really causes sudden cardiac death? What is the pathophysiology? What is the thing there that causes people to die? There's something called vulnerable myocardium. That is, a myocardium is the thickness, the heart muscle, the major heart muscle itself. Vulnerable means that any trigger can make it beat or work abnormally, and the person will just go down, become breathless, complain of chest pain, become weak. And if you do not intervene within seconds, you just find that the person would actually go down and go down and down and down and down till they die. So even excitement, somebody who has had a weak heart, vulnerable myocardium. Myocardium is that thick heart muscle, the main heart muscle that pumps blood out of the heart. Is already vulnerable, is already weakened. And then you now have excitement. Some people have all these problems that they inherited, but we don't know. So if you're so excited, it can trigger arrhythmias on the vulnerable myocardium. And this slide is very, very important in the sense that it talks about the triggers of sudden death. Triggers of sudden death, I'll try and quickly run through it. You see, here you have ischemic disease, you have heart failure, you have channelopathies, you have a unusual thickness of the wall of the heart. Then you have Wolff-Parkinson-White syndrome. That is, these are all diseases that, in layman's terms, they're inherent abnormalities of the heart rhythm itself. So you now have all this in the person, and you have triggers and modulators, and it keeps on progressing towards a final stage, final arrhythmia, going through arrhythmia, ventricular fibrillation. That's usually fibrillation means the heart just beating erratically when you already have a weakened heart because of something you inherited or something that you acquired. So that leads to sudden cardiac death. You can see the most common one, which is the acute myocardial infarction, the heart attack, is shown in this slide as partial blockage. These are all the shawarmas, the hamburgers, all the oily food that are stuck to the vessels, reducing blood flow to parts of the heart and making it die. And this is the heart attack. It leads to sudden cardiac death. So again, this shows the same thing. Then several studies have mentioned about that pinpoint stenosis. That is a kind of stenosis that is a blockage of areas of the vessels of the heart, which can lead to death. And that is what happened. That's what they found in the autopsy of the late man that died, the R-Jolad that died from autopsy. So again, arrhythmia, your heart beats so fast every day, it goes about 100,000 times a day. The heart is a strong organ, but when it's diseased, it gives you some time before it starts showing possibility that it's going to die suddenly. So that's ventricular fibrillation. You have the normal heartbeat, normal synchronous heartbeat, starting from the upper part of the heart and going to the lower part of the chambers of the heart. This is the myocardium. The thickness of the heart is making sure that the heart pumps out blood regularly to the other parts of the body and we feel good. But when it starts fibrillating, you see, the ventricles will quiver and it will beat so fast and irregularly. And we found that it gives this pattern on ECG. And the person cannot get blood out so easily, and sudden cardiac death can occur if there's no intervention. So that's chest pain. The patient will present. How will they even present? How will somebody who may have sudden cardiac death present? Fainting spells, like you see in this slide. Palpitations. Palpitation doesn't mean, oh, you see this large amount of money, your heart start beating, or you're in love with someone, your heart start beating, or you're worried about something, your heart start beating. It has to be persistent beating of the heart, of palpitations, and then that could be the sign of sudden death. So that's it there. So here in R-Jolad, if you present early without chest pain, that's fatigue, that's fainting, and we know that, and you come here early, time is of the essence of survival. Time of presentation, the quickness of response, and we can assure you in this hospital that our operations are lightning fast. The medical officer, nursing, and consultant assessment happens very, very fast. We'll assess you, place oxygen, make sure you're breathing, you get an IV access, get your blood and analyze it with the state-of-the-art point of care. Everything is done within seconds here. Give you a very, very strong chance of surviving in R-Jolad Hospital. Our point of care testing is very advanced, and so we do all tests rapidly and synchronously. And so that's why we have very positive outcomes of 99.8% survival rate of the major adverse cardiac events, preventing them in R-Jolad here. So most of the time we do a chest X-ray, echo, then cardiac cath. We have collaborations with places we can do a cardiac cath immediately. We have a CT on site, that is a cardiac tomography on site. MRI to designated centers, though one is coming up on stream. So most of us here have the basic life support and the advanced cardiac life support training. So we respond to patients with chest pain who could die suddenly in an advanced fashion. And we do it according to the standard of care based on world standards in R-Jolad. So these measures can help to achieve the greatest public health benefits. So like I said, we stabilize you, we go ahead, and we do the definitive care. So this is the certificate that most of us have, the BLS, basic life support and advanced cardiac life support. This was done in the United States. And so if ventricular fibrillation occurs, what do? We have to resuscitate you. And if it's happening outside the hospital, you have to call for help. You have to call for help one way or the other. And you start your cardiac compression. Start your cardiac compression, you check the pulse and make sure the patient is breathing. You shock. And here, in the hospital here, in-hospital resuscitation of us who has fibrillation, we have our defibrillators in almost all the hallways here. We keep on checking them for functionality. We have in the emergency room and most of the wards. And so this is a photo of people trying to apply the AED, automated defibrillator. So, like I said, this is how heart attack occurs. The heart muscle is damaged. So it's a medical emergency when someone is having chest pain and having symptoms, you have to come to the hospital. And so we make our diagnosis, that's the ECG, typical ECG, but there are some non-typical ECGs too. And we sort of experienced some here, which was the Wellen syndrome. And when we had the Wellen syndrome, we had a catastrophic outcome, but at the same time, the patient presented very late. But basically, this is the ECG that shows you about what is going on in the heart of the patient. And we have ECG machines all over everywhere. So this is just the photo of a train carrying your cholesterol into your heart and trying. Hello, can you hear me there? Okay. So we want to avoid some foods that are high in cholesterol, which are organ meats and sausage and bacon, saturated vegetable oils, and poultry skin, and most of this information, red meats once in a while. And the dietary approach to fats. Cholesterol is a form of fat. And it's better a person goes for unsaturated fats more than saturated fats. Those kind of oils that are just thick, that are solid in room temperature, most of them are containing trans fats, and you need to avoid that. You need to take on more of the oils that are sort of liquid at room temperature. Avoid most of those packaged cookies and bakery goods that have shortening, buttered popcorn, reduce all of that, and all those potato chips and packaged cookies. So, like I said, trans fat increases your bad cholesterol and is strongly linked to coronary artery disease. Several studies published in the Journal of American Medical Association of Cardiology reveal that an additional 6.2% decrease of heart attack and stroke in some New York counties where trans fats were banned. So there's a direct link association between trans fats, cholesterol, and the prevalence or incidence of heart attack. So this is more information about the relationship of cholesterol to ischemic heart disease. It's not done in Nigeria here, it's done in other places, but what applies there can apply here too. What happens there can apply here. So dyslipidemia, abnormal cholesterol, we talk about lipoprotein A, known to be prothrombotic. All this we can access here. We can analyze your blood and get out the lipoprotein and find out whether you have a predisposition to major adverse cardiovascular events, which can lead to sudden cardiac death. And there are some studies that also talk about the RR interval analysis program as a predictor of intervention when it comes to implantable cardiovascular defibrillator. They call it the ICD. This information was from the National Institute of Cardiology from Warsaw, Poland, which was presented in an abstract recently in Brazil. And they talked about the predictive marker of sudden cardiac death in patients who have the ICDs. That once they see runs of premature ventricular complexes, you can almost say that this patient is predisposed to having sudden cardiac death even though the patient is wearing an ICD. So they developed a basic computer program called the PCRR and applied it for RR interval analysis. This is a bit advanced for non-cardiologists, but at the same time, we just want to prevent sudden cardiac death from happening. So again, if you think generally and worldwide, we talk about things we should avoid, things we should enjoy. Yes, we can have a little taste of everything, but when we make the wrong foods continuously in our lives, it can actually build up to a risk factor for sudden cardiac death. So if you look at this, edible oils, which oil is really, really good? Which one should we even take? Which oil is good that we can take? The most supreme or superior kind of oils that we can take is the olive oil. It's very common out of the country. But here we use it for prayers, which is okay. But I've seen people who have actually drank a whole bottle of olive oil before. and developed a lot of diarrhea. You don't need to drink a whole bottle of olive oil to prevent cardiac death, but it's at least it's very almost low, very low in cholesterol, almost non-existent in it. So the most healthy oil you can use to cook to prevent sudden cardiac death is the olive oil. So talk about eggs again. Can we eat eggs or not? Can egg lead to sudden cardiac death? Some people say don't eat eggs. I'm eating eggs and I'm still alive. And I love eggs, but it's the quantity you eat. 1 egg per day is okay. It's not associated with mortality from cardiovascular death or cancer. That was found out by the Spanish European prospective study, EPIC Spain. And precautions about eggs, it doesn't apply to children or adolescents because it contains a lot of nutrients. Young people need those nutrients to grow. And several studies have revealed that it's just about a quarter of the study population that had these eggs that was actually susceptible to increase in cholesterol from diet, just about a quarter. And we have to be careful when you analyze the effect dietary cholesterol has on the amount of cholesterol we have that can lead to atherosclerosis and sudden cardiac death. We have to take into consideration that the current studies available now that is circulating in the scientific community are small randomized controlled trials. They are small, so we cannot really extrapolate those studies to the general population, but it can give us an idea that it's not everybody that their cholesterol will increase if they eat eggs. So the summary is that you can eat 1 or 2 eggs. And there's the egg politics too. Several studies have revealed that it's those people who are really, really trying to sell their eggs that sponsor the research for people for scientists to say that eggs are not bad, but eggs contain cholesterol. And so just that genetic susceptibility to developing hypercholesterolemia, it's very individual and it's about a quarter of the population based on current studies. So the risk factors for heart disease, heart attack that can lead to sudden cardiac death, you can see from this slide. It's quite clear. Then intracerebral hemorrhage, stroke, high blood pressure, stroke, narrowing of the blood vessels, and again, bringing it home. This was a singer. Many of you will know if you are older, in middle-aged generation or younger. This was a person who went to the United States, came back, died suddenly, sudden death. This wasn't a sudden cardiac death, but an autopsy was done. And sudden cardiac death, sometimes the only time you can find out the cause is by ischemia in the brain. So again, management is fast. You have to do something when somebody complains that, oh, part of my face doesn't feel right. Part of my leg is weak. I have trouble seeing in one eye. I have trouble seeing in the other eye. I can't walk very well. I feel dizzy. Get that person to the hospital quickly enough. I have trouble speaking. Or we just notice that a sister's voice is not as clear or slurred. That could be a stroke that's about to happen and can lead to sudden cardiac death. So we have to act. So again, pathophysiology of stroke, I've explained it that there's just blood clots blocking vessels going to part of the brain and leading to stroke. And that leads us to pulmonary embolism also, that is blockage of the respiratory system. And one person that people will know who was prominent, who was a minister in Nigeria, also died of pulmonary embolism. Probably they did the autopsy or not, we really don't know, but you have to know that these diseases are no respecter of persons. Once you feel the signs and symptoms, you have to take action quickly. And the way this hospital is built now, the founder and the chief medical director has created a very conducive environment for patients to survive. The likelihood of survival of a patient that may go to sudden death is very high here. The likelihood that they will survive is very high in R-Jolad here. So the risk factors for most of these diseases, like pulmonary embolism, you have DVT, deep vein thrombosis. age greater than 70, obesity, malignancy, autoimmune diseases, air travel, then the coagulopathies. We've seen patients here that young people who their blood will just clot and they'll be breathless, they'll faint. You resuscitate them, you don't find any risk factors for their blood clotting. And if there's absence of obvious reasons for their blood clotting, it's something that could be genetic or hereditary. You have the factor V Leiden, you have protein C, protein S, antithrombin deficiency, so many lupus anticoagulants in women, so many of those kind of conditions that it's better searched for and not assume that it's not there. On the advanced level, you need to search for all these risk factors and make sure you can tackle them before it causes the patient to die suddenly or the relative of the patient to die suddenly. So the clinical features of clotting in the lungs, you have dyspnea, tachypnea, chest pain, pleuritic pain, and syncope. So like I said, sudden death itself cannot be totally understood without autopsy. It may be too late for the patient, for the deceased, but for the relatives who have a kind of connection to the deceased, it can allow the relatives to go for early checks. Patients who have died suddenly below the age of 40, their relatives can go for, it can prompt them when, based on the findings from the patient in autopsy, can prompt those relatives to come to places like R-Jolad for some cardiac risk factor modification or genetic testing. And it stands them at a better chance of survival and not dying how their relative died. And everything is scientific. So like I said, channelopathies, long QT syndrome, Brugada syndrome, all these are very rare, but they're not so rare. They're rare because we've not just found them, we've not tried to look for the reason why somebody died suddenly. And our condition here in Africa is not helped by our religion and our culture. Some people bury their dead within 24 hours of death. They don't bother to find out why the patient died. There's still a lot of mystery about deaths here, but when we have the mind of searching, trying to help ourselves understand ourselves better and preventing sudden cardiac death from happening to us, then we have to go that step further. The step further is to actually do those genetic testing and pursue the reason why somebody died prematurely. And most of them will go through this sudden cardiac death will go through malignant arrhythmias. The heart will just start beating erratically, and before you know, the person collapses and dies. So you have the Brugada syndrome, Purpura death syndrome, sodium channelopathy. It presents like with syncope, the person will just be fainting, be in a meeting, the person will just switch off. Or the person is swimming, the person will just switch off. The person is singing, the person will just switch off. Or the person is doing some matrimonial responsibility, the person will switch off. And you wonder and wake up again, you wonder what's happening. It's a condition that is not apparent. That kind of person will need an implantable cardiovascular defibrillator. God forbid, if that person switches off, faints while driving, you know what can happen. So we have all those ECG advances. Short QT syndrome, Roman-Ward syndrome. There's so many like that that can kill a person. So you have the long QT syndrome diagnosis. In male, the criteria is different. In female, the criteria is different. So this is also talking about the different types of long QT syndrome. That is, you just have a pulse, instead of the heart relaxing, heart cycle, cardiac cycle relaxing, you have a prolongation. Once there's a prolongation, that person has a tendency to go to fibrillation or torsades de pointes, fibrillation, and sudden cardiac death can occur. Person will be exercising, it just faints, swimming, like I mentioned, sex, female is commoner in female sex, or even while the patient is sleeping. Remember that 7% of patients actually they can actually not wake up, and that would be the reason why they died in their sleep. So the latest info is genetic testing is important, and you'll see that these are all cardiologists in Nigeria. Many cardiologists, my teachers and my mentors who went to France on conferences, we have to exchange ideas. That is Dr. Oga there, Professor Mbakwe, Professor, a lot of them, Balogu and Co, and several others. And we exchange ideas and scientific information with the world. So this information is what we try to use in R-Jolad here to make sure that we give our patients the best. So the latest information about studying cardiac death is also that some modifiable risk factors have been identified and divided into metabolic factors, behavioral factors, psychosocial factors, and also environmental factors. The environmental factors is quite important. It's something we ignore. That is pollution. Pollution comes from particulate matter. And you talk about particulate matters and also pollution coming from traffic. It's very common in Lagos. And people don't realize that once the air is dirty and you breathe it in, it goes into your lungs and your heart. It can actually accelerate atherosclerosis in you. And that's the basis for the MESA air study that was published in 2016, where a group of researchers actually came together and measured the air quality and related it to the likelihood of developing atherosclerosis and sudden cardiac death. And they found out that there was a significant association. So air pollution itself is a risk factor, it's an environmental factor that can cause you to die suddenly over time. And this is usually ignored. That's why sometimes it's good to just live in the rural areas. Lagos is, we live in Lagos. Lagos is terrible when it comes to some areas have very bad air pollution. And talk about China too, on a worldwide level, and some areas of the United States. And that's why people want to move to the suburbs and rural areas where the air is cleaner. And when we have trees and we have nature, they act as the carbon sink. We act as pollutant sink. So we should favor more green areas in our cities and avoid air pollution coming from factories and vehicles because they are cardiac risk factors. So unfortunately, we're doing ourselves a disservice if we don't acknowledge ailments that are like high blood pressure. People will have high blood pressure and they will not take their medications. Please take them. When there is high blood pressure and you have a congenital or hereditary weakness in the aortic, in your large vessels in the body, and you don't know, and you have that high blood pressure, you don't know, you have weakness in your blood vessel, you don't know, aortic dissection can occur, and it will just tear, the blood vessel will tear there before the person knows it, he ends up dying suddenly. That's aortic dissection. And this slide shows about the risk factors: hypertension, Marfan syndrome, existing aneurysm. These are all conditions that we diagnose in the hospital. But generally, make sure that you check your blood pressure regularly. So that's aortic dissection. The vessels is normal there, and you have dissection, that is breakage in the wall. So different types, debarking, Stanford. Management, when you do the cardiothoracic surgery with the stent there. So it's often fatal, 30,000 deaths in the US every year. So we talk about the futuristic prevention of sudden cardiac death, which is that in R-Jolad here, we felt, let us move forward into the future. How do we make sure that we respond to a patient who will die suddenly in R-Jolad and help and make that difference? We want that rapid detection of situations that can lead to sudden cardiac death. We have the automated electronic and automatic defibrillators everywhere. But at the same time, we want to make sure that we want to create an app that can tell us where the defibrillators are in the hospital so that if anybody falls or there is a sudden need for a defibrillator, you can look at your phone quickly and say, yes, this defibrillator is in this place, and we can grab it straight away and shorten the response time to be able to help the patient survive. So that's what we're doing now. So sudden death itself is an interplay of lifestyle choices and environment. It comes together with genetic kind of predisposition, heritable, acquired, age, interplay of several things, environment. That interplay, when it comes together, it can lead to sudden death. So that's where I'm going to end the talk and give you some time for questions. Thank you very much.
Thank you, Dr. Ade. It was a very informative session. So in the chat, we have 3 questions. The first one, he says, please, can the doctor suggest relevant tests to be conducted to identify if there are major risks or signs of sudden death one needs to watch out for?
Yes, thank you for the question. The kind of tests we can carry out to prevent sudden cardiac death are what we do in the ambulatory clinic here. We make sure that based on the age of the person, most of our patients are above 40. At that time, you have mostly acquired causes or likely causes of heart disease or likely causes of or risk factors for sudden cardiac death. It starts from your blood pressure. We help you manage your blood pressure efficiently and give you scheduled appointments. We make sure that you are not diabetic. If you're diabetic, we control it. We control your blood sugar. We also look at your serum uric acid, which is also a risk factor for heart disease, and which has been recognized by the European Society of Cardiology recently as one of the baseline investigations. We do that here also. We make sure that if that uric acid is high, we try to bring it down to normal. And then again, one of the tests we also do here is to make sure that if you're experiencing chest pain, we don't take it that, oh, it's peptic ulcer disease or any other, or indigestion. We think about the worst that can happen to you, and we go through the algorithm of chest pain. You get an ECG straight away and a troponin using our state-of-the-art handheld analyzer, which tells us the level of a hormone or an enzyme coming from your heart. We can tell us whether you're going to die or not. And that's the troponin I and troponin T. So we do all those tests. Once you're normal, you can say that your risk of sudden cardiac death is reduced to the barest minimum.
Okay, thank you, sir. Mr. Samuel asks that, can a diagnosed first-degree heart block be reversed? Since it is asymptomatic, will it progress or remain the same under proper lifestyle management?
Yeah, a first degree. Yes, heart block itself, you have type 1, type 2, and type 3. Type 2, A and B is there, movies 1 and 2. So type 1 is benign. I mean, like you said, is asymptomatic. But once you see type 1, just observe the person and see what happens. Type 1 can be associated with so many diseases. Type 1 heart block can be associated with hypertension. Diabetes can be associated with structural heart disease. Structural heart disease. At the same time, it may just be something that you find as an incidental finding in a normal person. So the kind of management is you observe, repeat ECGs, and see whether there's a progression from type 1 to type 2 or to type 3. Most of the time, patients with type 1 heart block has nothing to worry about. But at the same time, in the R-Jolad here, we try to follow them up with scheduled appointments. Hello, are you there?
Yes. The next question, can a hypertensive patient participate in fasting?
Can a
That's
hypertensive
patient
patient participate in fasting?
Yes.
Yes, a hypertensive patient can participate in fasting. It's based on your religious commitments, but from the cardiology point of view, you need to control your blood pressure, and taking your medications with a little quantity of water should not be something that should affect your commitment to your God or to your fasting or to the tenets of your religion. Taking your medications it's not a form of food. So taking your medications is more or less a wisdom thing that, yes, I need to take I recognize that I have hypertension and I need to take my medications. Yes, you can take your medications while you're fasting.
And the fourth question, is it possible for Bell palsy, stroke related, to have a normal phase after years in Bell patient?
The question is it normal for somebody who has a facial deformity in stroke to be normal after a year, right?
Yes.
Okay, This question will be better answered by a neurologist. I'm not a neurologist, but at the same time, from patients we've seen, the recovery of neurological deficits in patients is very diverse, and it's very, very much individual. Some patients will have, and also based on the type of stroke the person has that led to that facial deformity. It's been documented that patients with hemorrhagic stroke, that is bleeding in the brain, have very serious neurological deficit, which is dense at the onset. So the facial deviation may be very, very significant at the beginning, at the onset, for patients with bleeding in the brain. But once the bleeding stops and over time, they recover, and that facial deformity can recover within probably 6 months. But if it's ischemic stroke, that is the kind of stroke that happens because there is a blockage, partial blockage of blood vessel of the blood vessel and blood supply to the brain. Ischemic stroke can be mild at onset, that is the facial deformity can be mild initially, then it takes a longer time to recover. So it depends on the type of stroke, and at the same time, individual variations are there. But it's better you refer this question to a neurologist rather than a cardiologist. Hello?
Oh, okay. The next question, should someone on a hypertensive drug still bother about a one-off chest pain and mind skipping? You know, in your talk, you mentioned that part of the signs is the chest pain that shouldn't be ignored, and they should come in to check at the hospital. So is this something that after a one-off pain, they should ignore or still come in?
Okay, the question is that somebody who is hypertensive and now has chest pain on one occasion should ignore, whether they should ignore it or not, or come into the hospital. My answer is, please come into the hospital. Come into R-Jolad and we'll do a cardiovascular screening for you. And we'll be able to say whether that chest pain should be ignored or not, because it will be a precursor of something more catastrophic, or it may not be anything. But you need to come to the hospital for a specialist management and review. Next.
The next question. Please, what do you recommend for primary care GPS to do suspected sudden cardiac emergencies?
The question is,
GPS.
what do you suggest for a what? Sorry, please. Sorry, I didn't get the question.
Please, what do you recommend for primary care GPs to do suspected sudden cardiac? I think that question itself is not clear, Mr. Eniton.
Yeah, I can hear you now. What do I suggest for?
I think we should just go to the next. We'll come back to it. The question is not quite clear. Okay, a patient was diagnosed with high BP and placed on hypertensive drugs. I have done ECG and all internal tests and shown all to be normal. But with the drugs taken and rest, I'm getting some fast heart rate. Could this be side effects of the drugs like Jotan, amlodipine, and indiscotin?
Okay, by my understanding from your question, you said this patient has been taking medications and
You can go ahead, Doc.
Hello, are you there?
Yes, we can hear you.
Okay. The answer to that question about, or the person is taking their medications for hypertension, they get home and they have a fast heartbeat. The answer to that is that if you have a fast heartbeat when you got home and you feel uncomfortable with it, you cannot breathe well, or you feel like fainting, or you have a chest pain with it, please come back to the hospital. You need a better review. Maybe some drugs, well, it's very rare for antihypertensive medications to cause a fast heartbeat because many of the antihypertensives that we use actually reduce the heart rate. So if that happens, that you have a fast heartbeat when you get home on antihypertensives, please come back to the hospital for an evaluation and we'll be able to help you.
Right, thank you, doctor. The
You're
next
welcome.
question. At what stage should one consider surgery to correct structural heart disease?
The question is, at what age should one
At what
consider
stage?
surgery? Stage.
Stage. At what stage? Yes. Should
At what
one
stage
consider surgery to
should one consider surgery to correct structural heart
structural
disease?
heart disease? Yes.
Yes. The stage at which you correct structural heart disease is when you find out that you cannot cope with activities of daily living. Once there is exhaustion or you've reached the terminal end of medical management, if with medical management one cannot carry out activities of daily living, one needs to correct it. And then again, in young people, in babies, it's much better to correct any structural heart disease at that young age than to wait for the person to grow older. This question is better answered by a pediatric cardiologist in that section. But adults who have structural heart disease, once they cannot carry out their activities of daily living without symptoms, they should go for correction. Hello, did you get
Okay,
me?
doctor. Yes,
You're welcome.
got it. The next one, are there specific exercises that is recommended to prevent some of these conditions that can lead to sudden death?
Yes, the question is, are there exercises that one can do to prevent sudden cardiac death? Yes, there are exercises one can do. The first one is that one has got to accept exercise as a lifestyle change, as a lifestyle thing, not necessarily exercising and stopping. Enjoy exercise just like you enjoy going out, watching movies and so on like that. And one wants to do what we call resistance training and also cardiovascular training. That is, you want to make sure that you do cardio by running at least 30 minutes most days of the week, 30 minutes for most days of the week, running or walking based on your body mechanics. Walking fast, 30 minutes most days of the week for cardiovascular endurance. That gets the heart stronger. Once the heart is stronger, it functions at a better and more efficient level. And then weight training. Weight training also helps the body to function better and strengthens the heart helps the heart to pump blood, oxygenated blood to all parts of the body. And the person can actually feel better. And the outcome is usually better. And this can prevent sudden cardiac death. So as the heart is growing stronger, the likelihood that you have high blood pressure is much, much, much lower. And your glucose control, which is also much important, the glucose control becomes better with exercise. So like I would recommend 30 minutes of walking fast in a safe neighborhood, at least most days of the week, at least minimum 3 times a week, and lifting weights also. If there's a gym around your house, join the gym, lift weights, go through that, let the gym instructor guide you as to the use of weights, and continue daily. Make it a routine. Don't make it a start and stop thing. I know most people are pressed for time, but start. It's better to start than not to start. So those exercises, but before you start any exercise, you need to see your cardiologist first. Do the general and basic investigations and let him be able to clear you for exercise. Next, please.
Thank you, doctor.
You're welcome.
The next question. Is regular heartburn a symptom of cardiac-related issue?
Is regular heart block a what?
Heartburn, a symptom
Of
cardiac-related issue.
yes, the question is heart block a symptom of cardiac-related issues? Yes, heart block is associated with several cardiac conditions. Heart block is associated with hypertension.
Sorry, doctor, I meant heartburn. Heartburn.
Oh, heartburn. Okay.
Yes.
Okay. Heartburn. Yes, heartburn is important. Well, heartburn is important. I'm glad this is about the best question that you've asked. Heartburn, belching. If you are belching, if you have heartburn, come to the hospital for screening. Because anatomically, your esophagus and your stomach is very close to your heart. Heart attack, sudden cardiac death can be like heartburn. Heartburn can mimic the pain of a heart attack about to happen. So if you say it's just heartburn, it may just be something else. It may actually be chest pain of sudden cardiac death that is starting. Come, let us tell you that this is heartburn and this is not heartburn. Don't say this is heartburn and you sit down at home. When you are, especially when you are above 40 and you are much more prone to ischemic heart disease, a lot of people eat a lot and they have heartburn when they want to sleep. Mountains of food. If you see some people eating, you will know that there's really no starvation in Nigeria. They develop heartburn. But at the same time, when you develop this heartburn, it can be a sign of heart disease because the thoracic plexus, the nerves that supply the esophagus, also supplies part of your heart. So they're closely related structures. If you're having repeated heartburn, you can take your antacid, yes, but coming to the hospital, let us tell you that this is heartburn, this is not heart disease. Comprende? You understand?
Yes, understood.
Okay.
One of the participants has a question about an hypertensive patient who was consistent with his medication and follow-ups consultation with the cardiologist, also with adherence to the advice, or he ended up dying of pulmonary embolism 2 months afterwards. So the person would like to know what would have been the cause of this and how better can we avoid the repetition in future.
Okay. So the question is about someone who died of pulmonary embolism and was hypertensive and has always been taking the medications and going for clinic visits. If this is the question, if this is the question, well, the answer is that pulmonary embolism has to do with throwing of clots from any source of the body, but most likely the legs, into the lungs. That is pulmonary embolism. That is blockage of the vessels in the lungs and the person cannot breathe well. The pathophysiology, that is the way it happens, is similar to a heart attack, that is sudden cardiac. Like I mentioned in my presentation, pulmonary embolism is one of the causes of sudden cardiac death. The person may have an acquired cause of that pulmonary embolism. Maybe the person has just gone to Canada, flown to Canada on a continuous flight, or Australia, long haul flights, or just have a rare genetic condition whereby the blood of this person has a tendency to clot, to thicken more than the others. I've seen that kind of patient here in R-Jolad, where you have a young man of 35 suddenly faints and comes to the hospital. You find out that he has blood clots everywhere and he's not taking anything that is making his blood clot. And you find out that you have to ask for all those, what they call rare genetic disorders that can lead to clotting. They say rare because maybe some people don't, maybe it's not well searched out for. No, once there is a cardiac condition and the person comes to the hospital regularly, the high likelihood of sudden cardiac death is reduced. But when you talk about pulmonary embolism, it will have been given some signs and symptoms before the person dies suddenly. And if it happens suddenly, it may be that the real cause has not been discovered. So there are two diseases of different pathophysiology, but also similar. But at the same time, the conclusion is that pulmonary embolism itself, the risk factors are similar to heart disease, but at the same time, they are separate. So it will mean that some other things led to that pulmonary embolism, and it's very rare like that. Next question, please.
Yes, I think this will be the last for today. We want to thank everyone for participating fully. The last question is, what do you recommend primary care HCPs, GPs do in suspected sudden cardiac emergencies?
Okay, very good question. Once a patient comes to you, the age is very important. The age is very important. If somebody presents to you at an early age, before the age of 40, in that graph I showed you, if somebody presents with chest pain before the age of 40, the likelihood that the patient has ischemic heart disease or myocardial infarction is very low. That likelihood is low before the age of 40. But if the patient still has chest pain, you still need to rule out a cardiac problem. So you go through the algorithm, you admit the person, you make sure that you place oxygen, you make sure the patient is breathing, you get an IV access, you draw blood, you look for certain markers in the blood. Troponin is very important. You do the baseline laboratory tests, full blood count, total and differential, electrolytes and urea, urinalysis, uric acid, random blood sugar, and the cholesterol. Do it for all your patients that come in with chest pain. Don't assume that, it's just ordinary chest pain, maybe it's muscle or something. No. Young people nowadays there's drug abuse in Nigeria. Drug abuse can predispose to having heart attack at a very young age. So you got to be very much aware of this. Order all those baseline investigations for young people. Order the troponin also, and we'll tell you whether this patient is having a heart attack. If the patient is above 40, that is even much more relevant. If the patient is above 40, you want to make sure that you do that same thing too. Make sure the patient has the airway intact, is breathing, and you get an IV access. You draw the blood straight away for the full blood count, total and differential, electrolytes and urea, urinalysis, uric acid, random blood sugar, and the blood glucose. You do all that, and then the troponin, ECG. ECG. Chest pain means ECG. Chest pain means ECG. And if you know that you are not so comfortable with ECG, snap that ECG and send to a cardiologist. You can send it to R-Jolad here, who will analyze the ECG for you and give you a feedback and tell you what to do. A lot of hospitals do that with us, as well as myself. I receive a lot of ECGs from peripheral hospitals and I interpret it for them and send it back to them. Those peripheral hospitals are our spokes because Bagada here is our hub for R-Jolad, but we have other spokes. So spokes means other branches of R-Jolad multi-specialist hospital in Lagos. The doctors there, we've trained them that if you have any patient with chest pain, some of them are medical officers or general practitioners. Any chest pain, you go through the algorithm. Make sure your patient is breathing. Make sure that you have placed oxygen, IV access, draw the blood straight away. Place, especially the troponin, do the ECG, chest X-ray. If you don't understand ECG, send it to the hub here, which is where I am here as a specialist cardiologist, and I will interpret the ECG and take a decision, even though I may not be there or the patient is far away. So for all GPs, you need to have a cardiologist as a backup for your operations. That makes you a very safe doctor. You don't have to know everything in detail because you're a generalist. But for high impact diseases that are major, that can lead to major adverse cardiac events like heart attack, you must have the backup of a cardiologist and do an ECG. Stabilize the patient, do an ECG, send it to a cardiologist, get a return, and manage the patient accordingly. Have I answered the question?
Yes, thank you, doctor. And can you please unmute your mic, Mr. Muyiwa? Hello? Hello, Mr. Muyiwa, can you hear me?
Yes, I can hear you.
Thank you.
Hello? Hello, can you hear me? Hello? Hello, can you hear me? Hello?
Yes, go ahead, please. Yes, go ahead, please.
Oh, okay. I'm sorry. It's like I can hear some echo. I'm calling from very far away. I'm at the moment here in Australia. I was one of your patients before I left Nigeria just last year. I just want to ask, does heavy snoring have any bearing to heart disease? Please, I hope you can hear me.
Okay, I can hear you. You asked the
Thank
question
you.
that does snoring have any relationship with heart disease?
Yes,
The
sir.
answer is yes. The answer is yes. It does. Snoring has to do with inhibition or prevention of adequate air getting into the lungs due to obstruction of the flow in the oropharynx. Yes, once that happens, you have period of hypoxia, that is lack of oxygen to the heart and to the brain, periodically when the person is snoring. And when that happens, initially it may be asymptomatic, but over time, it can lead to what we call cor pulmonale, that is stress on the right side of the heart. And once the right side of the heart develops disease, it affects the left side of the heart. So the heart itself can fail over a period of time if there is snoring. It's called obstructive sleep apnea, and it can be corrected. Most of the time, when people snore, it may be positional, and you may need to adjust your position to prevent snoring, or it may be due to rapid weight gain. So you may need to try and reduce some weight, which is challenging, but you can achieve it. And the other thing is, if those preventive measures don't occur, don't kind of solve the problem, one can go into what we call sleep studies and go on to the CPAP, use the CPAP, continuous positive airway pressure. That will help increase the flow of oxygen to the lungs and to the heart and correct the snoring. Sometimes some people advocate palatine surgery or surgery in the oropharynx to widen the oropharynx, but most of the time, snoring can be taken care of by preventive measures. Try to lose weight, or you change your position, or you see a sleep specialist who will determine what is going on and be able to correct it. But yes, snoring over time can lead to pulmonary hypertension, that is high blood pressure in the right side of the heart, right heart disease and left heart disease, and a failure of the heart. It can also lead to arrhythmia, as the heart will just beat erratically. That's over time. So it's good to correct snoring. Next, have I answered your question?
Yes, you have. Thank you so much. It's unfortunate that we didn't get to examine this while I was still in Nigeria. But hopefully I'll be back sometime later this year. Then
Okay.
I'll come back and see you. Thank you so much. I think you answered the question.
You're welcome.
Thank you, sir.
Yeah, next, please.
Okay. To answer Mr. Valentine about our locations, yes, R-Jolad locations, you can come in for any of these tests as mentioned by Dr. Adebuya. We have locations in Isolo, we have in Agege Orile, we have a spoke at Penn Cinema, and a spoke also at Jara Mall Ikeja, and also a spoke in Bawala. And the branch 2 in Bagada, where we have the standard building and the plus building. So yes, you can come in for the test, and we have specialists on ground like Dr. Adewiya, and yes, you can call in. I think that will be all for now. Do we have any other questions? Okay, the last question. Yes, someone just asked, is R-Jolad registered with HMOs? Yes, you can use your HMOs if registered with R-Jolad Hospital. Yes, you can. The last question, what is the major cause of blood clots on the vein? Can the clot lead to severe body pain? And what is the solution to this clot? From Mr. Joseph.
Okay.
Doctor, did you get that?
The question is, there are blood clots where?
Okay.
What is the cause of blood clots where?
In the vein.
In the vein.
Yes,
Oh, okay, yes. Like I mentioned, some conditions predispose to blood clots in the veins. Some, it can be hereditary and it can be acquired. Hereditary means that some people just have bad veins in their legs, and that can predispose them to blood clotting in the veins in the legs, and then they are throwing blood clots into the lungs and they cannot breathe well or it can cause stroke. That is hereditary. Then some people can have some abnormal proteins in their blood that makes their blood just clot. Like I mentioned, they are hypercoagulable. They just have this tendency to clot because of some random genetic variation or mutations. So when that happens, then you need genetic testing. Genetic testing to discover the highly effective load of what is really going on, those genes that are abnormal in you, and to really know that you may have to be on medication for life if the cause of that clotting is hereditary. That's the reason why genetic testing is important. But if it's an acquired cause of clots in the body, like you've traveled to Australia, you are sitting down, sedentary lifestyle, you're always sitting down, you've traveled so far to Canada, you're back, 13-hour flight, or you sit down for a long time, or you have that problem with thickening of the vessels, like pollution also, like I said, pollution also can affect the thickening and narrowing of the vessels, or roughening of the inside of the vessels that leads to the tendency to clot. Then if you remove those factors that are likely leading you to clot, then the person will not likely clot. But when it happens, and we know that in the hospital here, there are medicines you can use. They are called anticoagulants. And we've managed several cases of patients like that here in R-Jolad. Patients will shuttle from mainland to island every day for 30 years. At the same time, when they now come to R-Jolad here, they say, "Doctor, I have pain at the back of my legs." You do a scan of the legs so that they have blood clots. They're always sitting down, they go slow between mainland and island, and that kind of thing. That kind of stasis, that is the blood just standing there, and they wear tight shoes and they just sit in the car. Like that, we tell them, you have to make sure you remove those tight shoes. You try to be ambulant. Instead of sitting down all the time, they don't exercise, they don't do anything. But we give them anticoagulants. That is something to clean their blood, and they do well. We've had almost 100% success rate here in managing people who have blood clots. So I hope I've answered your question. Hello.
All right, thank you so much, Doctor. I think that will be all for today. We've all been informed. It was a vast topic that everybody participated and gained 1 or 2 from. Thank you for all joining. And thank you, Dr. Adewiya, for delivering this so well. That will be all. Then for all asking about our locations, we're going to share
Presentation slides.
the PDF of our location.